Greetings and welcome to the GENMF Primary Care Leadership Program Colloquium on Women's Health. Today's moderator is Dr. Tonore, Associate Professor and Residency Director of Student Programs of the Department of Family Medicine at the University of Mississippi School of Medicine.
Welcome to the Primary Care Leadership Program Scholars Colloquium on Women's Health. I'm Dr. Tonore. I practice family medicine at the University of Mississippi School of Medicine. We are going to have presentations from students who have worked this summer in Jackson, Mississippi, Nashville, Tennessee, and Los Angeles, California. Through the topics they have chosen, we will deal with health care that spans a woman's lifetime. They have presented some innovative ideas and some questions that bring thought to how we treat women and deliver their health care. Now our students will present their topics.
Hello everyone, my name is Summer Bailey and I'm a second-year medical student at the University of Mississippi Medical Center in Jackson, Mississippi. This summer for 6 weeks I was placed at the Jackson Hines Comprehensive Health Center in Jackson, Mississippi, and the title of my program was the Strong Start in FREMIS, providing education to current and expecting mothers to benefit the children of Mississippi. The objective of my program was to create educational materials for Jackson Hines Comprehensive Health Center and the Strong Start program to help improve the education of women who are either wanting to conceive or already pregnant. My methods included speaking with various providers along with the coordinators of the Strong Start program to determine where the most educational need existed and gathering data and information in order to get stuff to make my materials. Then I collected educational materials based on these findings to suit the needs of the women of Jackson Hines in the Strong Start program. Last, I distributed these materials to the Jackson Hines main site and medical mall sites, along with other sites involved with the Strong Start and FREMIS programs. The key findings in my experience were that women that were already wanting to conceive or already pregnant are unaware of the everyday decisions that they must make it less likely for them to conceive and to avoid having a premature baby. Additionally, finances and insurance are two issues that many Jackson Hines patients face and cause them to not know or make the decisions best to become pregnant or to ensure that they have a healthy pregnancy. For the site, I recommend that through the education of parents, through physicians, along with having a generalized list of guidelines that mothers can use, mothers or women wanting to conceive can know and make the best decisions possible to have a successful pregnancy and reduce the chances of having a premature baby. So basically a reflection on my experience at Jackson Hines Comprehensive Health Center is that it's a wonderful place. It gives people that don't have the money or finances or opportunities that others have to get health care, and I'm very happy that I got a chance to work there this summer.
My name is Tiffany Brandon. I attend the Medical University of South Carolina. I'm a second year in the College of Medicine program. This summer, I was placed in Jackson, Mississippi at the Jackson Hines Comprehensive Health Center. The title of my project is Considering Breastfeeding, Here's What You Need to Know, Patient Education on the Benefits of Breastfeeding. The Center of Disease Control and Prevention Immunization Survey collects data on the rates of breastfeeding and uses it to create a breastfeeding report card. Data is collected in several categories, including ever breastfed, breastfeeding at 6 months, breastfeeding at 12 months, exclusive breastfeeding at 3 months, exclusive breastfeeding at 6 months, and a number of other categories. The rates of breastfeeding for Mississippi mothers rank 50th in the majority of these categories. Ever breastfed, breastfeeding at 6 months, and breastfeeding at 12 months, Mississippi mothers rank 50th for their rates of breastfeeding. Exclusive breastfeeding at 3 months, Mississippi mothers also rank 50th. Exclusive breastfeeding at 6 months, Mississippi ranks 49th, beating out Tennessee by 1 percentage point. The objective of my project was to determine if mothers in Mississippi are deciding not to breastfeed because of lack of information about the benefits of breastfeeding, also to educate mothers about the benefits that breastfeeding provides, and to learn about mothers' perception of breastfeeding. My methods. Surveys were verbally administered to expecting mothers and mothers in childbearing years. Surveys attempted to determine expecting mothers' likelihood to breastfeed, their perception about breastfeeding, and their exposure by obstetric providers about the benefits of breastfeeding. Surveys attempted to examine mothers in childbearing years' record of breastfeeding, their perception about breastfeeding, and their exposure by obstetric and pediatric providers about the benefits of breastfeeding. Handouts were also used to provide information to expecting mothers. Handouts included information on why you should breastfeed, how breastfeeding benefits your baby, how breastfeeding benefits you, how long you should breastfeed according to the American Academy of Pediatrics, what WIC, Women, Infants, and Children, does to assist breastfeeding, support groups for breastfeeding moms, including La Leche Leagues, lactation consultants, and breastfeeding classes. Contact information for the Mississippi Department of Health, lactation consultants, and the University of Mississippi Women's Care. There is also a section named More Information, where mothers could visit websites and find out more information about breastfeeding. My results. 59% of expecting mothers reported their OB physician never mentioned how breastfeeding benefits mothers. 47% of expecting mothers reported their OB physician never mentioned how breastfeeding benefits babies. 56% of expecting mothers reported their OB physician never mentioned breastfeeding classes or support groups for breastfeeding moms. 42% of mothers in their childbearing years reported their OB physician never mentioned how breastfeeding benefits mothers. 44% of mothers in their childbearing years reported their OB physician never mentioned how breastfeeding benefits babies. 26% of mothers in their childbearing years reported their pediatrician never mentioned benefits of breastfeeding. 37% of mothers in their childbearing years reported their physician never mentioned breastfeeding classes or support groups for breastfeeding moms. Nearly 3 out of every 5 expecting mothers surveyed had never been informed that breastfeeding helps reduce their risk of some cancers and will help them return to their pre-pregnancy weight and shape faster. Almost half of expecting mothers reported their OB provider never mentioned that breastfeeding helps decrease their child's risk for being obese, sudden infant death syndrome, developing asthma, and developing diabetes. These percentages closely resemble the number of mothers that decide not to breastfeed as reported by the CDC. Roughly half, 49.5% of mothers reported never breastfeeding, which may be attributed to the greater than 50% of mothers that are never educated by providers on the benefits of breastfeeding. My recommendation is for Jackson Hines Comprehensive Health Center to become baby-friendly. Jackson Hines is already in the process of completing some of the steps necessary to become baby-friendly. One of those steps involves the creation and implementation of a breastfeeding promotion and support policy. My project will play an integral role in the completion of this step by creating a policy to provide handouts to expecting mothers throughout their pregnancy to explain the benefits of breastfeeding. The development of a newborn class that promotes breastfeeding as well as provides other information about how to care for newborns and infants will also be able to fulfill some of the steps needed to become baby-friendly. I hope my time at Jackson Hines Comprehensive Health Center will bring attention to the lack of patient education on the benefits of breastfeeding in hopes of increasing Mississippi's mothers' rates of breastfeeding.
Hello, my name is Nicole Coppage, and I'm a second-year medical student at USC Keck School of Medicine. I was placed at AltaMed in Los Angeles, California, and today I'll be presenting the preliminary results for my project focusing on family planning practices, as well as the role of pediatricians in increasing interpregnancy intervals in Latino women served by AltaMed. A number of studies have documented the negative impacts short pregnancy intervals can have on both mother and child. Unfortunately, 23% of Latino births are preceded by a less than 12-month pregnancy interval. My project stemmed from a prior observation in one of AltaMed's pediatric clinics, where women bringing their children in for a 0 to 12-month well-child checkups were asked whether they were planning on having another child. Though many of the women indicated that they did not wish to have a child anytime soon, Many also stated that they were not utilizing any form of birth control when they were subsequently asked about their family planning practices. Now, amongst adolescent mothers, we know that birth control usage increases postpartum, but rates of discontinuation are often high due to lack of education, lack of parental support, and most importantly, it seems to be a loss of continuity of care. Now, while this has been well documented amongst adolescent mothers, it's unclear exactly how pervasive this phenomenon and these factors are amongst all mothers, specifically in a low-income Latino community. Furthermore, since care for new mothers often ends at 40 days postpartum, whereupon the focus of health tends to shift from the mother onto the child through 0 to 12-month well baby checkups, um, there may be opportunities available for pediatricians to discuss family planning during these well baby visits. Therefore, the goal of my project was to understand how current family planning practices relate to future pregnancy intentions in the low-income women served by AltaMed, and how comfortable these mothers would be to discuss family planning with their pediatrician. So the way we went about doing this is we first developed a 19-question survey to be administered to 150 new mothers during their 0 to 12-month well baby visits. However, before rolling this out to so many patients, we first needed to identify any issues with comprehension, clinical logistics in administration, and relevance to our stated project goals. So at that point, what we did is we kind of did a test survey amongst 10 women to hopefully discover these issues before we rolled it out to the larger patient population. Unfortunately, due to the short summer, we were really only able to test the survey, and we were unable to expand it to the larger 150 woman pool. However, from our preliminary results from these 10 women, we did find that although all the mothers surveyed indicated that they did not want to get pregnant this time, 2 actually responded that they were not using birth control. They listed lack of insurance, lack of knowledge about options, and safety as barriers that prevented the use of birth control other than condoms specifically. What was particularly interesting is that almost half stated they did not have a women's health provider, and all of the women not already on birth control said that they would like their child's pediatrician to speak with them about family planning options. So, though this is an extremely small sample size to pull any conclusions from, it does suggest that family planning goals may not necessarily match up with family planning practices, and that there are a number of barriers that can be contributing to this. More importantly, the lack of women's health providers and the unanimous desire to have their child's pediatrician speak to them about family planning options indicates an exciting opportunity for pediatricians to provide this family planning information and link patients with further care. This may be the first step in actually reducing these interpregnancy intervals in this community. So future directions with this project include first modifying the survey for both length issues and to better focus in on the goals of this study. Once this is completed, we hope to deliver this survey to 150 women receiving care at AltaMed to better understand this issue and how pediatricians can play a role in mitigating its effects. So thank you very much for your attention. Feel free to contact me through email with any questions or comments. Thank you and have a nice day.
Hello, my name is Tiffany Jackson. I attend Mercer University School of Medicine. I'm a 4th-year medical student in an MD program. My GE NMF Primary Care Leadership Program city site was Jackson, Mississippi at Central Mississippi Health Services Incorporated. My project was to understand the utilization of healthcare services, a female perspective. With this study, I wanted to understand the utilization of healthcare services by women between the ages of 15 and 35. I chose this population of women in their childbearing years due to the decreased likelihood that they would be followed by an internist or a family medicine physician, and the increased likelihood that they would see their OBGYN more frequently. I also chose this age group because of the decreased likelihood of having chronic illnesses. Most women over the age of 15 are no longer seeing their pediatrician for childhood well checks or immunizations, and women under 35 have not yet got to the age where they're doing a lot of their screenings and a lot of other preventative care that takes place after that age. The methodology used for this project was a survey that was given to women between the ages of 15 and 35 to complete prior to their appointment in the waiting room. The survey asked the question of who their primary care physician was, if they had a primary care physician, and when was the last time they had a visit. Other questions on the survey included their last ER visit, how often they go to the ER, when was the last time they went to the ER, and what type of health situation they were going to the ER for. I also asked whether or not they had been diagnosed with any chronic illnesses, and if they saw their OBGYN more often, or if they saw a primary care physician like a internist or family medicine physician at all. The results of the survey were quite interesting. Greater than 70% of the females identified their OBGYN as their PCP. 90% of them did seek preventative care annually in the form of a pap smear and other blood work that can be done in an OBGYN office. However, more than 70% of the women had visited the ER more than 3 times in the last 3 years. Some women had visited the ER more than 15 times. Most of the ER visits were for non-emergent care and non-urgent care. For example, a cold or a boil without sepsis and without pneumonia. This study indicated that due to the decreased likelihood that this population of women would receive chronic management of disease, that there may be an increase in inappropriate use of emergency care, which has been shown to increase the cost of health care in our United States healthcare system. A study by Dr. Peter Cunningham that was presented to the United States Senate Subcommittee on Primary Health and Aging in 2011 stated that although there was an increased use of the ER by insured more so than Medicaid or uninsured populations, the cost savings is greater in the uninsured and Medicaid population when there's a shift from the emergency room to community health centers. Most average visits cost about $1,200 compared to a community health service visit, which is about $20 to $60 per visit. His study also indicated that the increase in ER use reflects the increase in need for ambulatory care by this population, as well as showed that increased use of ERs causes overcrowding, also causes decreased time for the physicians in the ER to actually address real emergent situations or mass trauma or casualties. Therefore, it is very important that each community look at the dynamics and look at specific populations. For example, in this study, women between the ages of 15 and 35, to understand how different populations utilize health care so that we can decrease ER visits and streamline patients into community health care centers so that they can have better quality care, have better follow-up, and decrease the high cost of health care in the United States. My recommendations for all community health centers are to have a OBGYN on service at the clinic, which Central Mississippi Health Services does have. If you do not have the option of having OBGYN services, it's important that community health centers have relationships with other OBGYNs in the community where these patients can be redirected and introduced to these community health care centers so that they can be picked up and followed as patients, so that when they have ambulatory care needs, they can go to the clinic instead of to the ER. I would like to thank Dr. Smith, my website advisor, and I would like to thank Dr. Shannon Pittman, my faculty advisor, and Dr. Michael Livingston, who was also very influential and helpful in allowing me to speak with his OBGYN patients as well. I want to also give a special thanks to GENMF Primary Care Leadership Program for giving me this wonderful opportunity. I thank you and I appreciate it. Thank you and have a nice day.
Hello, this is Rashida Merchant. I'm a second-year medical student at the Commonwealth Medical College in Scranton, Pennsylvania. I was in Nashville, Tennessee at the United Neighborhood Health Services. There I worked with the Strong Start team. The Strong Start team works to provide information and healthcare for women who are pregnant. The team emerged because of very high infant mortality rates and low birth rates in the community. I worked with the group to try to set up prenatal yoga classes based on research that shows the benefits of prenatal yoga in women who are pregnant and at risk for different diseases. I also worked with a local community center to set up yoga classes for children in the community. And again, this was based on research and statistics that show Nashville has very high rates of obesity among children. This project entailed not only setting up classes, but also gauging the interest for yoga among pregnant women through a short questionnaire, and also conducting informal interviews with children who participated in the class and with advocates of prenatal yoga. Though the questionnaire showed among pregnant women that there was a strong interest in prenatal yoga, it was difficult to set up the classes due to many barriers, such as finding the right time and transportation for women. However, United Neighborhood Health Services do plan to set up a class for pregnant women and continue promoting prenatal yoga in the community. The class for children at the community center was very successful. It lasted 6 weeks, and children showed strong interest. The instructor reported that she noticed a difference among the children's attitude and behavior. Perhaps most importantly, the children enjoyed the class and had a lot of fun participating and attempting the different poses in the class. Recommendations for United Neighborhood Health Services include continuing these classes into the year for the children and next summer, as well as promoting prenatal yoga for pregnant women and developing handouts and videos that show the different poses for pregnant women. While I was an intern at United Neighborhood Health Services, I learned a lot about community medicine and community healthcare. I saw firsthand the many challenges communities face and the many challenges they will face in the future. I also had a chance to see the unique and different and creative ways community health centers are tackling some of these challenges. And the whole experience is really, really hopeful.
Hello, my name is Jaylene Sims, and I'm a third-year medical student at Southern Illinois University School of Medicine. My placement site was Central Mississippi Health Center Incorporated in Jackson, Mississippi, and the project that I implemented was called Love Your Heart. So the objectives of Love Your Heart was to heighten the awareness of the signs and symptoms of heart disease and heart attacks. I also wanted to inform women how to prevent heart disease. And then last, I wanted to assess the knowledge gained from the heart health presentations. So the methods, I developed and conducted a 10 to 15 minute presentation that I would conduct to women. They were one-on-one or sometimes in small groups. They were between the ages of 17 and I think the highest may have been around 92. 58 women received education. I also provided a survey with open-ended questions to just ask women what they learned from the different sections of the presentation. 27 women actually completed the survey. And the reason why there's such a big difference between the 27 and 58 is that I conducted a presentation for one of the women, and then she invited me to a women's group in the community. So I didn't actually have them do the surveys because the time was limited. So the key findings, 53% of the women said that they learned about cholesterol, basically how cholesterol affects the heart and the vessels and how it can cause the symptoms related to heart disease. 40.7% of the women reported learning about the symptoms of a heart attack and kind of how they're different for women compared to men. And then almost 26% of the women reported that they learned about the risk factors associated with heart disease. Now regarding nutrition, 52% of the women reported that they learned about starchy foods. So basically we talked about the difference between starchy and non-starchy vegetables and the different foods that would count as being starchy and how they affect their body. 37% of the women reported learning about portion sizes. And then when it comes to exercise, 37% of the women reported that they learned something about exercise, what counts as exercise, how long you should exercise, how often, things like that. So from the project, I came up with a few recommendations, and so there were some educational opportunities. Nutrition was one of them. Basically, just making sure women know the difference between starchy and non-starchy vegetables. There were lots of confusion in that topic area. And then heart health, cholesterol, how it affects the cardiovascular system. I think it's really important to kind of know the subsequent events that can take place once someone is diagnosed with high cholesterol, how it can block the arteries and then the blood flow decreases. And then once the blood flow decreases, you get chest pain. I think when people kind of know that, they're more likely to make lifestyle changes. They're more likely to adhere to their healthcare plans. The next recommendation is to make sure that we always consider health literacy when conducting patient or community education. There were so many women that really told me how they appreciated the fact that I paralleled a lot of the language. So when I used hypertension, I also said high blood pressure. That way they kind of knew, the medical term and the terms that we may use in the community. Then last, 48% of the women actually reported being interested in learning more about women's health topics, such as hysterectomies, breast, cervical and ovarian cancers and cysts, sexual health, breastfeeding, and menopause. So those are some future areas that we can kind of think about educating women about. So when I reflect on this entire project, I actually thought of a few things. I really love interacting with and educating young ladies and women. So while implementing Love Your Heart, not only did I educate them, but I was also able to learn from them. They were very happy that I took the time to sit with them, and they even told me about some of the experiences that they have had with heart health. And because of that, I was able to incorporate that knowledge into the next presentations to help the next woman. So overall, I learned that sometimes our biggest teachers are our patients themselves. So overall, I really enjoyed this experience and I learned a lot. Thank you.
Hi everyone, my name is Rosie Tom. I am a second year medical student at the Medical University of South Carolina. This past summer I was a participant in the GE NMF Primary Care Leadership Program. I was placed in Jackson, Mississippi at the Central Mississippi Health Services. My project this summer was to assess and improve patients' awareness of breast and cervical cancer screening recommendations. The objective of my project was to evaluate patients' current knowledge and health behaviors related to breast and cervical cancer screening. And then I wanted to provide information to patients on breast and cervical cancer incidence, death rates, risk factors, screening recommendations, and available resources in the community, as well as promote a sense of empowerment in understanding one's own healthcare needs. My methods for my project was surveying patients' knowledge of screening recommendations and their relevant health history and current screening practices. And then I provided a short PowerPoint with information to patients on breast and cervical cancer and recommendations. And then after that, I discussed with patients what they felt how often they should be screened in the future based on the recommendations and their personal health history. In addition, I used clinic data to evaluate the clinic's effectiveness in adhering to recommendations. My main finding was that patients' understanding of recommendations was limited, yet many women were still receiving screenings according to recommendations. For example, 5% of respondents knew to start pap smears at age 21, yet 88% of women aged 21 to 65 had received a pap smear within the past 3 years, which was the recommendation. In addition, 18% of women knew to start mammograms at age 40, yet more than that, 3% of the women I talked to had already received a mammogram within the past year. In addition, I found that patients were very receptive to learning about recommendations and the resources available to them in the community. Based on my findings and through talking with patients at the clinic, my recommendations are that providers should continue to remind patients when they are due for a screening, and in addition, make sure that they explain why and what tests are being done and what those tests test for. Another recommendation I had was that the clinic should use brochures and community resources to promote regular screening. I was really interested in doing this project because I felt that it was an opportunity to talk with patients about their health needs as well as improve their education on health care. This was a really important topic because currently the recommendations are kind of confusing regarding breast and cervical cancer, especially since multiple organizations conflict with each other and they've been changed recently. So part of my project was for myself to understand the different recommendations, and I basically took the different organizations such as the U.S. Preventive Health Services, the American College of Obstetricians and Gynecologists recommendations, the American Cancer Society's recommendations, and then I also took into account what the clinic was already doing and what their recommendations were for patients, and from there I kind of drafted what was the recommendations I was going to tell the patients. In addition, I found it really interesting to talk to patients about tests that were done at the clinic because it sounded like many patients believed that when they were getting a pap smear, it tested for cervical cancer, it tested for sexually transmitted diseases, when really it's only testing for cervical cancer. And that was an important point for patients to understand, that if they wanted to be tested for something else or they weren't sure what they were being testing for, it's really best to talk to their doctor. In conclusion, this was a very educational project for me in understanding how to talk with patients and how to understand their healthcare needs, as well as helping them become empowered in voicing their needs and expectations in the healthcare clinic. I really am grateful that I had this opportunity.
opportunity, and thank you very much. Have a great day.
The topics that have been presented span the scope of decisions that women make about their health care. One common theme is that patients do not have all the information they need for the best choices. There were several ways to disseminate this, and the key is going to be education. Specifically, we need to decide how our patients accept information. What is their educational level? Can they read and comprehend written materials? Do they do better with video or audio presentations? How are we going to deliver this to them? Also, finding resources for our patients and helping them connect with what is available will be necessary. Two presenters refer to Strong Start in their work. This is a program that helps pregnant women get financial aid from the state and also some aid from WIC programs, Women, Infant, and Children programs, which helps with nutrition and providing nutrition. Yoga classes. How common are they in your area? How can they be started and maintained in more rural environments? All of these things will work to promote better pregnancies, better outcomes of pregnancies, better children at birth with good birth weights, and the optimum development stages they had during the pregnancy. There were several mentions of interdisciplinary work to promote good health. The women expressed they were comfortable talking to their pediatricians about family planning. We as physicians address adolescent family planning, but have we talked to the mothers? How comfortable are physicians at reaching patients outside their scope of practice? These are things that we need to consider and address. What we are after is getting people to help us with their health care, to make better decisions, to understand what their screenings need to be, to recognize signs and symptoms of heart disease as well as other disease processes. Patients learn in a lot of different ways. It's going to be important to match our delivery of information with how our patients can receive it and use it. I came up with 3 questions about these presentations. Number 1, what will be the best way to disseminate information to our patients? What about social media? Your generation is all about social media. But just 1 to 2 generations before you, social media was not even discussed. We had snail mail. So how can we best teach our patients to access the information that we want to provide? Who will be responsible for delivering that information? Will it be medical students? Will it be interdisciplinary practices? And how will we train other disciplines to be comfortable with disseminating information outside their scope? Number 2, who are our patients? How will we identify who needs this information? Do we just deliver it in our offices when problems have already arisen? Or do we need to go to where the patients live, where they can be reached in their own environments, schools, churches, social groups? Number 3, what other gaps in women's health care have we not discussed? How can we promote good decisions? Who will be the decision makers? And how will you, as medical students, contribute to improving women's health for the next generation? Thank you.